Hello, today we're discussing atrial fibrillation in light of the most recent ACC AHA guidelines. We move from at risk for AFib to pre-AFib to AFib to permanent AFib. AFib should now be thought of as a disease in stages, emphasizing early intervention as being important and viewing AFib as a holistic disease continuum rather than discrete duration-based episodes. The decision permanent AFib simply means you've decided not to do any further interventions on that patient and you're going to focus mainly on symptom management. The clinical problem overall, 50 million people have AFib. It's associated with a 2.5 times increased risk of stroke, 5 times increased risk of heart failure on an average. Triggers for AFib include ectopic beats predominantly from the pulmonary veins. The underlying substrate is structural remodeling, interstitial fibrosis, left atrial enlargement. The important thing is, early after depolarization, calcium mishandling may trigger the initial AFib, but AFib begets more AFib through atrial myopathy. There are 3 pillars of care. The basic foundation is going from head to toe, making sure that you address underlying risk factors such as obesity, lack of exercise, alcohol, etc. Then you assess the stroke risk and then optimize the modifiable risk factors and comorbidities, and then symptom management for rate and rhythm control. Obesity is an important target. You should target at least 10% weight loss in those with BMI greater than 27. This is strongly associated with reversal of AFib type and improved ablation outcomes. Hypertension is the highest population attributable risk factor. Strict GDMT control reduces major cardiovascular events. Sleep apnea, 1 in 5 patients with AFib have sleep apnea. Treatment reduces AFib burden and post-ablation recurrences. Alcohol has a dose-response risk. Abstinence or reduction drastically cuts AFib burden. Binge drinking and extreme or elite endurance exercise athletes both have distinct triggers for AFib. Now, to stratify stroke risk, we commonly use a CHADS VASC score. CHF gives a point, hypertension a point, age more than 75 2 points, diabetes 1 point, stroke TI or thromboembolism 2 points, vascular disease 1 point, age 65 to 74 1 point, and female gender 1 point. Score 0 for men and 1 for women is low risk, implying less than 1% per year stroke risk, no anticoagulation needed. Score of 1 or 2 for women, 1 for men is intermediate risk with 1 to 2% stroke risk per year. And here we are able to share decision making. Any score greater than 2 for men and 3 for women is high risk and oral anticoagulation is indicated. Now, to prevent strokes, the go-to medications are DOACs like apixaban, rivaroxaban, dabigatran, edoxaban. These are class 1 of first-line agents. They have a lower risk of intracranial hemorrhage. No INR monitoring is needed. Vitamin K antagonists are mandatory for moderate to severe rheumatic mitral stenosis or mechanical heart valves. Should never use DOACs in patients with mechanical valves or moderate to severe rheumatic mitral stenosis. Warfarin is the only drug for this. Non-pharmacological alternatives include left atrial appendage occlusion. This has been upgraded to a class 2A for patients with non-reversible contraindications to long-term anticoagulation. Now, for those with device-detected AFib, once a high-rate episode is detected on a device, this should be confirmed with a monitor. Subclinical AFib can be episodes lasting 5 minutes or up to 24 hours or more than 24 hours. The longer duration increases the risk. Brief episodes of less than 5 minutes do not increase the risk. The risk reduction with anticoagulants is not as robust as in clinical AFib. Another point to remember is those with concurrent CAD status post PCI have increased bleeding risk on triple therapy. You have to balance the stroke risk with stent thrombosis risk. DAPT along with DOAC is initiated for about a month, then aspirin is dropped, as triple therapy significantly increases bleeding risk. Now, symptom management is done with AV nodal blocking agents such as beta blockers, metoprolol. These are the standard of care, highly effective, especially in high sympathetic states. Next is non-dihydropyridine calcium channel blockers, diltiazem or verapamil, the rapid onset and improve symptoms. Digoxin is best used as an adjunct in patients with limited tolerability to beta blockers or calcium blockers. You should remember not to use calcium channel blockers such as diltiazem or verapamil in patients with heart failure or reduced ejection fraction. Target rates, lenient rate control is less than 110, strict is less than 80. Now, there's a push for early rhythm control. The clinical trials EAST and AFNet indicate that early initiation of rhythm control within 1 year of diagnosis results in a 25% less cardiovascular death, stroke, and heart failure hospitalization compared to rate control alone. Catheter ablation is now a class 1 indication in select patients as superior to antiarrhythmic drugs for maintaining sinus rhythm. Heart failure, reduced ejection fraction patients are the ones that benefit the most. The results for the Cabana, the Castle AFib trials show significant reductions in mortality and improved ejection fraction in these patients. Now, there's certain scenarios where you have to reverse the anticoagulation. In dabigatran, you should use idaruximab, which is a humanized monoclonal antibody fragment. Apixaban and rivaroxaban, we use andexanet alpha, which is a recombinant modified human factor 10A decoy. Coumadin or warfarin, you use vitamin K IV. Prothrombin complex concentrate is preferred over FFP for rapid reversal. Failure to achieve effective hemostasis multiplies mortality risk more than 3 times. Do not delay using these agents for warfarin when there is associated intracranial hemorrhage. For periprocedural interruption and bridging, patients on DOAC should basically stop the drug 1 to 2 days prior. No heparin bridge is needed. For patients on warfarin, you stop about 5 days prior, bridge only if there is high thromboembolic risk, such as a mechanical valve. Now, AFib is a continuum. You should manage holistically with head-to-toe risk factor control. Remember SOS, stroke, optimize, and symptoms. Stroke risk is associated or calibrated using a Chad's-Vass score. DOACs are preferred over warfarin. Warfarin is required for mechanical valves or rheumatic mitral stenosis. Early rhythm control less than 1 year of onset of symptoms improves survival. Ablation is class 1, especially for heart failure, reduced ejection fraction. Never use diltiazem or verapamil in heart failure, reduced ejection fraction. And do not bridge DOACs periprocedurally. Thank you for listening. More to follow.